break, and then I'll get into those other 50 da-da-da-da. Once I'm done with that, we'll send y'all out for lunch so that y'all can have that hour to do whatever it is that you love to do. So if I'm pushing you out at 11:30, then we'll start at 12:30, and then we'll go back and forth like that. And then once I'm done, she will be in here so that y'all can head on out and go get ready for that PEDS test. Okay? All right. So like I said earlier, right, everything, all of the 20 slide decks that we did first, that was all of the Derm stuff, okay? These things have some of the Derm skin lesions, abnormalities that are out there, but most of the important things with these is the rheumatological stuff, treating those the comorbidities that are more important, okay? So I'll be highlighting some of those the key concepts that are important as we're going through these things, okay? So first we're going to talk about SLE, systemic lupus erythematous. So a SLE, okay, it's an autoimmune disease characterized by potential multi-system involvement and production of the array of those auto-antibodies. We know that these things happen, you know, they can have some of that wax and wane, they can be having some of the flare-ups, and it's mostly because of the fact that the comorbidity is flared up and is causing them to have that. So it's that autoimmune disorders. Prediction is for females of that childbearing age. All right, so you can see the breakdowns there. White women, black women. We're talking about, you know, all of the Americans, other than those things. Because of the fact that we talked about those childbearing ages, we know that SLE is oftentimes early age at menarche. So they start that period cycle. They're on some type of an OCP, or if they've got some of that post-menopausal hormone, so it's once they get that older. There is that family history that is out there. Smoking is a large risk factor. Ranges from skin to joint involvement. Okay, so it's not only is it on of the outside of the skin, but it can get into the skin, so you can see those things out there. Basically, that's that photosensitive rash, so the malar rash that we're going to see in some of these photos, polyarthritis, serositis, fatigue. They also have that hypocomplementemia that may occur. Again, talked about those triggers: tobacco, UV, EBV, drugs, so procainamide, hydrolazine, ISO, some antibiotics. How do they features? Well, you get a classification, so we pretty much know that this is showing us some of those signs and symptoms of SLE, but we can also have that of a diagnosis. Diagnosis would be based upon that individual having 4 of 11 criteria in order to say, yep, this is what it is. And we're going to go over those. Should be emphasized, however, these are classification criteria were developed in an effort to standardize the patient being enrolled into clinical trials, da-da-da-da-da-da. Okay? SLE presentation is heterogeneous, so it's not just one, it can be either. None of these folks, yes, they only have to meet 4 of 11 criteria because they don't have to have all 11. Some will have certain ones, some will not. It just goes back and forth. Again, that's that family history. What did your mom have that now shows you having that as well? And we talked about the flares. So here's those 11 criteria that are out there. 4 of 11 would make that diagnosis. So malar rash, that's that rash of the upper cheeks. Discoid rash, photosensitivity, painless oral ulcers, arthritis, serositis, renal disease, neuro disease, hematologic disorders, immunologic, and positive ANA. Positive ANA is probably the one that's out there that everyone will have that, regardless of what other things they have. A positive ANA is usually seen with every single patient who is diagnosed with lupus. Again, that's a chart showing those same 11 things. So other things out there that they could be showing, it's not part of the criteria, but constitutional, they can have fevers, they can have that low-grade fevers that are showing those out there. They can have a fatigue, they can have weight changes. These are some of those things that can be associated. So we'll break them down. So here's that mucocutaneous. So 80 to 90% of those individuals will have mucocutaneous involvement at some point, right? We will be breaking that down into 3 types. So there is that bottom bullet, okay? Remember, there are 3 types. Acute cutaneous lupus erythematous, so acute, subacute, and chronic, so ASC. Those are the 3 things that are out there, and we're going to break them down and talk specifically about those things that are significant or the key components to which of that class it is. Back up top, talking about that majority of the skin reactions occur more than 1 week after sun exposure. And it can last for weeks, it can last for months. We have that patchy or diffuse alopecia. They've got that thin, friable hair. If that flare is happening, then they can have some of that alopecia happening. Nasal or oral ulcers, remember we said earlier, they are typically painless, but it's one of those things that we see. That criteria number 1 is the malar rash, and that's what the malar rash looks like. So that's up on those upper cheeks. So it's that butterfly malar rash, localized in that acute cutaneous lupus erythematous. This one does not spare that nasolabial fold because we learned about that earlier. So part of your differential diagnosis, if you have a face rash right in here, is that perioral dermatitis or those other things that would, go throughout that. So, which is exactly what I just said. So differential diagnosis, so acne rosacea, seborrheic dermatitis, flushing syndromes. How to differentiate? Well, rosacea, predominance of that telangiectasis and pustules that sting and burn, that heat, that alcohol, that stuff that makes that trigger. Seborrheic dermatitis, scaly erythematous plaques that occur with the eyebrows, scalp, behind the ears, commonly found with the nasolabial folds. So that's where those things look like. Again, a little bit some of the breakdown between acute and subacute. So on that top image, you've got that acute stuff. So it's on the dorsal aspects of the hands, of the fingers, of the thumbs. Whereas as subacute gets down into the lower back or back of the neck, extremities. You've got that alopecia, friable, oral ulcers. Remember, these are painless, so this is not causing them pain. One of the, I don't want to say a major, but one of the big abnormalities regarding lupus is known as discoid lupus. So it's more severe than those other things out there. This is a chronic thing. So this is not acute, it's not subacute, it is progressed. It's more severe. So we get that chronic cutaneous lupus. Lesions typically expand with peripheral erythema and hyperpigmentation. Leaves a hallmark atrophic central scarring, telangiectasia, and hypopigmentation as seen in those photos. Most commonly found on the face, scalp, or neck. Again, a subtype of that chronic cutaneous lupus erythematous is discoid. More of those description there of discoid. So you got that raised red patches, adherent keratotic scaling and follicular pudging. Affects 25% of these individuals out there. 75 of those afflicted with discoid lupus have that 5 to 10% increased lifetime risk for SLE. So, no bueno. With discoid that is different than acute, subacute, and chronic, discoid can have that oral stuff, but that does hurt. So a discoid lupus mouth hurts, SLE does not hurt. And here's that summary. So y'all can see it's breaking it down into these specific ones. So acute, generalized, they get that photosensitive maculopapular rash primarily on the hands. With acute, they get that malar rash on the face. Subacute, most photosensitive lupus, right? So we talked about if they're having some of that sun exposure. This one affects the torso, the limbs, but spares the face. So acute face, subacute not face. More often, drug-induced, so they're having some of that thing out there. And then the chronic, you get that severe stuff, so discoid, it hurts, so they've got of the pain associated with that one out there. So what are some of the other things that can happen with lupus? Well, it's those other comorbidities that are out there. So lymphadenopathy, okay? They can have this be localized or diffuse, soft and non-tender. Typically involves cervical and axillary nodes, right? So it's, you know, up and under those areas there. So that's what lymphadenopathy is associated with lupus. If enlarging or hard, get a biopsy, just because of the fact we want to see what it is that is actually happening. Musculoskeletal, we talked about how they can have some of that arthritis, right? So that's part of that criteria. 95% of lupus patients have this. Transient, symmetric, affects the hands, wrists, and knees. Seldom deforming, so it's not erosive or having that. Less severe than rheumatoid arthritis. Most common presenting feature of SLE is that arthritis. If it's, you know, getting into those bad spots, you can have that osteonecrosis. So a vascular necrosis can be associated with lupus as well. It can occur with or without injury, so it's not because of some overuse steroids or a high prescription dosage and stuff out there. It's just associated with that. Renal, so lupus nephritis, pathological evidence in up to 90% of patients, but only 50% is clinically significant. So we'll see those once we're doing the labs and that kind of stuff. So that'll help us to make that type of diagnosis that is out there. It develops in the first 36 months of that disease. Typically immune complex glomerulonephritis. Hallmark clinical finding is hematuria and or proteinuria. So you got some of the blood or the protein that is seen on that UA that we can see. Advancing renal failure, complicates assessment of SLE disease activity because they could be having an elevated ESR or of a CRP that is not indicative of that, but it could be one of those things that you're going to see regardless. Screening SLE patients at 3-month intervals is prudent. So that 24-hour urine protein for us to see those things, okay? So we talked about the lymph nodes, we talked about the muscle, we talked about the renal. What else? Oh, well, we'll keep going, because now we're getting into ocular. So they can have that keratoconjunctivitis sicca. So they can be presenting with that conjunctivitis. Lupus retinopathy. So they have that immune complex mediated vasculopathy. Microthrombotic events. Clinical findings. They've got those cotton wool spots, retinal hemorrhage, or hard exudates. So that's how they could be presenting with some of these ocular manifestations. Cardiovascular, Raynaud phenomenon, okay? 30% of these patients will have some of that Raynaud phenomenon, right? So we know that that's that red, white, and blue. It's that France stuff of the change of the way that the hands look like. They could also be having some pericarditis, maybe asymptomatic, but on occasion lupus pericarditis leads to life-threatening hemodynamic complications. They can have some of those valves getting thickened, right? So mitral, aortic valves, with or without non-bacterial vegetations. They can have CAD, they can have coronary artery disease. So SLE is associated with accelerated atherosclerosis and itself a risk factor for CAD. Pulmonary pleuritis is the most common pulmonary manifestation with SLE. Pleural effusions. Half of those people can have that. So pleuritic chest pain common, though some effusions are asymptomatic. Some of the rare things that can be happening in the lungs, rare, could be some alveolar hemorrhage and lupus pneumatitis. Interstitial lung disease usually occurs concomitantly with lupus nephritis. Okay? We've been together for what now, 4 weeks or so, and I've been telling you non-stop throughout, even since the very first one, that I am here talking to y'all who are going to be the future PAs in family practice and doing some of those things like that, okay? This is pointing out some of the aspects of what these rheumatological things are. Y'all are probably going to just be doing some labs and rads and this and that and refer them out, okay? So just stick with the key components. I don't need y'all to have to memorize all of this cray-cray shit, but again, we're going to go through next week and we're going to do a review. So I'm not trying to load your brain with all of this cray-cray stuff, okay? Gastrohepatic. So these lupus people can have that abdominal pain. Medication side effects, infection, just some of that stuff that are causing that to happen. Rule out non-SLE conditions first. So steroids, immunosuppressives, sleep causes that abdominal pain, so they have that peritonitis, pancreatitis, mesenteric vasculitis, interstitial pseudo-obstruction, hepatic LFT abnormalities, so we're going to see that once we're doing some of the routine regular lab tests. We'll see some of those abnormalities that are out there that can just help to push us knowing where it is that we want to have them go. If rule out medications or infections and still have persistent LFT elevation, then that would be us, setting them up to do of an ultrasound, a biopsy, to do those things out there just to see what that looks like. Talked about the neurological stuff that was out there. So talked about, you know, it's neuro, so it's everything. It could be CNS, it could be PNS. Those are those things out there that can cause their headaches, seizures, mood changes, cerebrovascular disease, cognitive dysfunction, myelopathy. All right, so it's just, yeah, I'm on your brain, your spine, and all those damn peripheral nerves out there. So we can see those things happen. One of the tests there, again, I would refer them somewhere neurological to do that lumbar puncture or do an MRI so that we can look at all of those special things. Again, I would refer, and I might just order an MRI just to go ahead and have them start the process of doing that. But it's not a question I'm asking them. There they go. Breaks it down, showing what is all of the CNS stuff, what is all of the PNS stuff. Hematologic, leukopenia. Half of those will have leukopenia. We can see some of that thrombocytopenia occurs with SLE patients. Hemolytic anemia. So we see all of those counts that are done out there. So bilirubin, LDH, haptoglobin, Coombs test. Yeah. Most common hematologic issue that lupus individuals have is anemia and chronic disease. So those are those things out there that are most common. And speaking of those lab findings, that's all of those up there. And this is not just one slide, there's another slide that has these things listed. So CBC, we'll see that leukopenia, like we talked about just last slide, that's in half of the patients having that. We can get a KIM, LFT, CK elevated, if they're having some of that myositis. UA, we talked about, that's that hematuria, that's that proteinuria. We'll also do some of that 24-hour urine. ESR correlates with SLE, right? We said earlier that ESR and CRP are always usually elevated with these SLE patients. Be elevated, but it doesn't always mean 100% that that is what it's pointing out. Okay? More of those antibody things, tests that are out there. So these are those special tests. With a negative ANA typically excludes SLE. A positive ANA does not secure the diagnosis, but I told y'all earlier, about 95% of people have a positive ANA. That is just showing that out there. But then it breaks it down into some of those other ones. So an anti-dsDNA, highly specific for SLE, anti-SM, anti-phospholipid antibodies, depressed serum complement, I don't like labs, but it's in the slide deck, so there you go, okay? Radiology-wise, we talked about earlier how we will be doing some of that chest x-ray, CT of the chest, an echocardiogram if we're thinking cardio stuff's out there, MRIs because we're trying to see CNS, PNS, all of those things out there. General principles, limited evidence-based recommendations, treatment tailored to specific manifestations and the severity of SLE. Just like rheumatoid arthritis, and just like everything that we've been talking about, and all of the other room stuff that we're going to go through, treat that comorbidity, treat that other thing that is leading into this, or is causing that flare. Treat that stuff more important than what you need to do for this in and of itself. Screening for complications. Okay. SLE may fall on the primary care manager. Okay, so hypertension, hyperlipidemia, vaccinations, bone health, cervical cancer screening. Those are those things that if you have that lupus patient, you know that this can cause all of that other stuff, so you just look into those things, want to treat those things, screen for that stuff. Most SLE patients are aware of their fillets and can help guide initiation, alteration of the therapy. Of course, we're going to send them to room. Talk about the ESR. Yeah. Non-pharmacological stuff. Photoprotection, cover your ass up. Stay out of the sun. Tobacco cessation, patient education, exercise, healthy diet, vaccination. If we're going to get into some of the pharmacological stuff, then anti-malarial agents. And those two listed there, so that hydroxychloroquine or chloroquine should be a part of every lupus patient treatment regimen. Okay? Of course, those things have side effects. We know HCQ is known as plaquenil. It's got that antithrombic and lipid-lowering effects. Most severe side effect of ACQ is irreversible retinopathy. So that's one of the side effects that are out there. Here's another big list of the things that are out there. So AZA, so azathiopine, microphenolates, methotrexate, leflunomide, cyclosporin, cyclophamide, intravenous immunoglobulin, so that IVIG. And then it breaks it down showing you some of those things that could cause. So AZA, first immunosuppressive agent added to HCP for non-renal manifestations. That one is safe in pregnancy. MMF is not safe in pregnancy because it can be of a teratogenic, so it could kill a fetus. Methotrexate, leflunomide, IVIG, yes. Rheumatology, you pick. Systemic corticosteroids. Y'all know how we can be using some of that low-dose therapy of the prednisone daily, but sometimes that has to be increased. Sometimes it has to be, for distant time with that taper out there. Very high doses for CNS lupus. So if it's we run through that neuro stuff, yeah, we're gonna let that neurologist go ahead and prescribe that high dose of a steroid, not us. But it's one of those things that you could send them out. If those steroids are not working, then that specialist can go ahead and get into some of that biological therapies. So belimumab, rituximab. So the only SLE medication approved by the FDA of biological aspect is that belimumab. Again, that is a specialist prescribing that. We're not even going to refill it. Follow up with your specialist. Consider in the patients with non-renal SLE. Rituximab, that's that second line agent. Of course, it's not approved yet by FDA, but it's one of those things out there. Now, just talked about all those medications, okay? Whatever, it's not us. This, though, can be some of the things that we are prescribing, okay? So cutaneous, we can have some of that topical steroids. We're either going to be low, medium, or high, depending on what it is, which level you're at, what have you already tried, what is not working, what are those things. So let's start off with that hydrocortisone. So let's start use first, that low potency. So we're going to start them on it, tell them, teach them, show them how they're going to be doing it, and schedule a follow-up so you can see if it's working. If it's working, stick with it, okay? If it's not, then we would get into some other things. So then we're going to be talking about medium potency. So triamcinolone, betamethasone, we gotta go high, then we'll go to clobetasol. This man up here uses topical clobetasol because of my damn psoriasis, but it works, so I stick with it. I don't use it like every day, I just use it when it's bad. So that's that high potency, clobetasol. Typically reserved for severe hypertrophic regions. Adrenal suppression can occur with use of high potency topicals. Y'all know those things. You can get into that second line agent, so that's that topical calcineurin inhibitors. We can do some intralesional steroids, so if it's located in one small spot, then I could use an intralesional because I'm just going to put it up and underneath of that plaque that is there. But if it's widespread, then we can get into those systemic options. So we'll get into the dapsone, cyclosporin, belimumab, IVIG. Those are those things that we talked about earlier in that more severe stuff. But us can start with that hydrocortisone. If it not works, then we can up it and up it. I like topicals. Others with some anticoagulations, some statins, some ACE, some ARBs, control hypertension with renal manifestations. So those are things out there. Complications of lupus, so the highlights, right? It's basically damn everywhere from the head to the toe, to the front to the back. It can happen anywhere. So end-stage renal disease, atherosclerosis, osteoporosis, avascular necrosis, infections, malignancies with that lymphadenopathy, pneumonitis, diffuse alveolar hemorrhage, right? This is like everything. Females, we talked about that childbearing age, multi-system diseases, common manifestation of those flares, right? So they'll have that malar rash, that photosensitive rash. So if they're out in the sun, that can happen. They get that arthritis, serositis, fatigue, renal disease, presence of ANA, certain autoantibodies. So you get that anti-dsDNA, SM. Those things are good if we're going to do that diagnosis. Again, I've never ordered an anti-dsDNA or anti-SM because that's what those specialists do. They have those things out there. So they're the ones who get to make that. I just have to see that and send them over. Drug-induced lupus, that's that side effect that is out there. Talked about classical associated with hydrazina, isazina, procainamide, those medications out there. Male and female are equal because of the drug-induced. It's where they were given that for. Nephritis, CNS abnormalities are rare, but they can be caused by a drug-induced. Often will present polyarthritis, myalgia, fever, serositis. Again, more of those things out there. Stop the damn drug. Stop the offending agent. Yeah. Lupus in pregnancy. Most SLE patients are women of the childbearing age, which we talked about, so they could be having that. Increased risk of disease flares. Oral contraceptives, so if they're on some of that OCP, that can be causing them to have that lupus stuff, yeah. Increased risk for poor fetal and maternal outcomes. APS, acute lupus nephritis, usually treatment options limited due to fetal risk. We talked about that MMF, that's that tetragenetic biological medication that's out there that can kill the fetus. We got this PATH acronym. So risk factors for poor pregnancy outcomes in lupus can be remembered by the PATH acronym. Proteinuria, antiphospholipid syndrome, thrombocytopenia, or hypertension. They can have those things, then that's going to increase their risk for having a baby. Yeah, pregnancy loss. Limited IUD, safe and effective for most patients who have that SLE, so they're obviously not going to get pregnant because they got the IUD, but it's not going to cause flare-ups and other things that are there. OCPs may be used in patients with stable low disease activity and documented negative antiphospholipid antibiotics. So you can use those things out there. Planning, again, that's APS essentials, so hypercoagulopathy, DVT, PE, stroke, renal injury, recurrent pregnancy losses, yeah, breaking it down. Those are those things out there. APS again, we got that acquired disorder with circulating antibodies to the phospholipids. So primary occurs independently, secondary in setting of autoimmune disease, so usually SLE. More of that stuff out there. Bum ba da bum 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 bum. I said a lot of damn stuff. But next week when I do this test review, you are going to know the things that I want you to know and to never forget and to remember forever. All of the slides of this rheumatological stuff is not a key component to those things, but Mr. Stupley has to stand up here and read it. Okay? It's like I'm a student with y'all because I'm not remembering this shit. And I teach it. It's just funny. Anyways. All right. Before a break, let's go ahead and press into these last 21 slides. So this one is a quick one, and it's just talking about Sjogren's syndrome. And then we will take a break, and then we'll do the other stuff thereafter. So Sjogren's. Okay, again, these, like, there was like one or two pictures, because this is not Derm stuff 100%. It's got Derm aspects, but it's not just y'all seeking this out. This is more just explaining. This is reading you the textbook of what these things are, because they coupled them up. All right, so Sjogren, chronic inflammation disorder mainly characterized by lymphocytic infiltration of exocrine glands prominently. Usually presents as a persistent dryness of the mouth and eyes. So they got all that dry stuff that is there. Basically, that is that functional impairment of the salivary and lacrimal glands. So the stuff that gives us all of that moisture in our mouth and in our eyes, we're having difficulty developing those things. We got two main classifications here. So we got primary, that is in absence of another rheumatological disease. Okay? So that SJS is absence in another rheumatological disease, whereas a secondary, it has another rheumatological disease, usually rheumatoid arthritis, systemic sclerosis, which we're going to talk about next, SLE, which we just talked about. So that is all of the secondary stuff, meaning it's a backup because they've got that rheumatological stuff that's already there, and so this is just added into it. If it's in and of itself and it's not having any other things, then it's just, that's where it's primary at. Primary affects white perimenopausal women. So that female to male ratio, you can see that is 14 to 1. So that's a big one. 2 to 4 million person in the U.S. with SGS. Most have secondary SJS. They most have secondary because they're having some of that other stuff happening. So they're having lupus or systemic sclerosis, rheumatoid arthritis. Okay. Here's those SICA features. So they've got that xerostomia. Subjective feeling of oral dryness is a key feature. 95% of the patients with Sjogren's have xerostomia. They can have some oral soreness, adherence of food to mucosa, or dysphagia. So dysphagia is what? That's where it's just hard to swallow. It's hard to get it down. And it's because all of their mucous membranes are not, fluid. Surface of the tongue becomes red, lobulated. They can have that angular cheilitis, similar to that Joker's mass that we talked about when we were doing that candidal infection in block 2. So erythematous changes of the hard palate, red tongue, atrophic papillae frequently occurs in SJS. Talked about that keratoconjunctivitis sicca, subjective feeling of ocular dryness. May have photosensitivity, erythema, eye fatigue, decreased visual acuity. They can also get some blepharitis, bacterial keratitis, conjunctivitis. So it's just messing up their things. Some severe eye reactions. So corneal ulcerations, vasculations, opacification, right? So these are sicca features of Sjogren's, but you could be seeing this it can look just like a regular person who's got blepharitis or has got conjunctivitis. One of the things that if you see it, you'll know damn straight for sure that it's Sjogren's is if the cheeks look like that. Okay? So you get that salivary gland enlargement, so parotid, submandibular, those salivary glands just get packed like that. So you got that look. They can have some of that airway dryness, right? So we talked about dysphagia, right? So they've got that stuff. So hoarseness, chronic non-productive cough. Not only could it be in the mouth mucosa, well, it can be down in the vajayjay area, right? So you've got difficulty of the dryness, itching. Those things out there can be there. Just like lupus, we talked about all of those systemic manifestations that could be happening. Well, that can happen here too. So generalized, they've got pain, fatigue, weakness, sleep disturbances, anxiety, depression, low-grade fevers. Musculoskeletal stuff, they can have that arthralgia, intermittent systemic arthritis, joint deformity. Skin, talking about that xerosis, small vessel vesiculitis, palpable purpura, urticaria, erythematous macules and papules, lungs, bronchial, interstitial, everywhere. More Raynaud phenomenon, similar to lupus, we can be seeing that with Sjogren's. Most common vascular feature observed in primary SJS. So that's that primary SJS, which SJS is the only one that they've got going on. They're not having those other things out there, so it's not secondary. Gut, uncommon, but of course with everything GI-wise, we always check H. pylori. Nephrourologic, 5% of this time happens. They get some of that renal tubular acidosis like lupus, glomerulonephritis like lupus. Neurologies, very rare, but they can have that cranial nerve pulses, so trigeminal facial, so 5 and 7. Endocrine, 30% can have that thyroid disease. Immunologic test, hey look, ANA, it's always high with these rheumatological things out there. But it breaks down RF, anti-RO, LA, da-da-da-da. CBC, mild, leukopenia, lymphoneutropenia, thrombocytopenia, elevated ESR, normal CRP. They're out there. Some more lab findings. Serum protein, LFTs, electrolytes, urine. Those are those things that can be seen out there. Another chart. Other things that we can be doing to get some of that diagnostic. A key component is an easy one, and we'll see that on the picture coming up. It's called a Schremer's test. basically you take of a paper, put it into the lower eyelids, and see how much fluid flows out to let you know if they're not having that. So salivary flow weight, CLF chemistry, CLF scintigraphy, which is shimmers. You can also do that ultrasound. So you can see that carotid enlargement, so they're having some of that thyroid stuff that is going happen. I talked about Schirmer test, corneal staining, salivary biopsy. That's that Schirmer, right? So you put it in there and then you're just seeing how much fluid will come out. And with these things, it's usually no bueno. Breaks it down into those things there. This is American European classification. So these are some of those criteria, things that are out there. Basically asking them questions and see if their answers are yes or no, yada yada. Patients with ocular or oral dryness defined as positive responses to at least one of the following questions. So those are the questions out there. I'm not going to ask you to memorize these questions. Exclusion criteria. Again, showing all of these damn things out there, okay? I'm not going to ask you about these criteria. Lupus criteria maybe, but not this one. Symptomatic treatment only, so dry eyes, preservative-free artificial tears, punctal occlusion, topical cyclosporin. If they're having that dry mouth, then we can use those palocarine, sevimyline, meticulous oral hygiene, or give them some sugar-free gum or candy, lemon drops. Drop it like it's hot, okay? Another treatments that are out there, organ specific, okay? So what is the other things that are happening that we're going to just treat those systemic disorder that is causing them to have these difficulties, what it is that we're going to actually give them, okay? So NSAIDs, corticosteroids, breaking them down. Primary SGH patients have the higher risk of lymphoma, right? So primary is that one. That's the only thing that they have. They don't have that other stuff that is out there adding to it. It is just that. So worse in cyclothemia, hyperlipidemia, palpable, purpura. Most common location of lymphoma is those parotid glands. What did I tell you is one of those easy things to see that you know that it's SJS. That looks like Mickey Mouse or something, but the ears are down, not up. Okay? All right, let's take a 10-minute break, so we'll start back up at A. So systemic autoimmune disease characterized by varying degrees of skin fibrosis, vascular damage, and wide array of internal organal dysfunction. We got two types of it. We've got fibrotic disease and vascular disease. Fibrotic disease, that's that skin tightening and interstitial lung disease. Limited cutaneous and diffuse cutaneous. So there's two manifestations, and then one of those, fibrotic, has two types of associated. So we have limited and we have diffuse, and we're going to break it down and talk about where those things are at in a bit. That vascular disease, that's that Raynaud phenomenon or pulmonary arterial hypertension. Again, with the sclerosis, we have localized and we have systemic. Again, breaking all of these things down. Raynaud, ANA, 95% of people, just like with lupus and that the other one can be seen. There is no universal pharmacological intervention, so there's not one thing that is used to treat these things, but we're going to talk about all of those things, okay? It's rare here in the United States. Women affected 4 to 5 more times. I'm sorry, women, all of this rheumatological stuff is just bullshit. Average age at diagnosis is 30 to 50. African Americans, Native Americans may have more severe disease associated. Prognosis is highly variable. Most common cause of death is cardiac involvement, followed by lung disease. The most common cause of death with sclerosis is cardiac involvement. All require evaluations by a rheumatologist. So systemic sclerosis part. Two main subtypes for systemic sclerosis. I talked about it's limited or it's diffuse. So with the two main subtypes, if it's limited, we get skin thickening confined to extremities, distal to elbows, knees. Face involvement does not mean they lack internal organ involvement, but it's more predominantly associated with that skin thickening confined to extremities, distal to the elbows and knees. Then we have diffuse, so skin thickening extending to the proximal portion of extremities and the trunk. Scleroderma, sign scleroderma, that's that rare subtype, but that's one of those things that is out there. So we can see in the picture over there that we see, that's that limited versus that diffuse. So that individual stuck in the middle, you see on the face, you see those extremities, whereas diffuse, it looks like everywhere. So it gets into that trunk. So let's talk about diffuse. Diffuse skin tightening of both distal and proximal extremities and or trunk, prominent flexion contra. So this is that one head to toe. You get that Raynaud phenomenon, digital ulcers, so that's that ischemic or traumatic. It looks like they chopped a tip of their finger off and it's bleeding. Interstitial lung disease, more frequent, often severe. Pulmonary hypertension, group 2 and group 3. Myocardial dysfunction, so more frequent. They also have that scleroderma renal crisis. From a GI, they have dysmotility, so that's difficulty for that shit to move, right? It's just stuck in the stone, because it's all that thickening of that mucosa that holds onto it. Musculoskeletal, more severe, small to large joints, get that contractures. Pain disability can be severe. Autoantibodies, they can happen there too well. So that was the diffuse, right? So we talked about all of those things there. Diffuse. Diffuse. Limited. So it's got skin tightening of the face and extremities, distal to the elbows, knees. They can also have calcinosis and telange. Phenomenon, they can have those ischemic digital ulcers too, interstitial lung disease, pulmonary hypertension group 1, but the myocardial dysfunction is rare here, right? We said that the most common of that diffuse is that cardiac involvement, not limited. The limited is rare of the other things that are diffuse, so scleroderma is one of those things. They can have some GERD, dysphagia, milder, mostly small joints. So limited is the one that we want if we have to have it, okay? Diffuse is worse. Again, there's a breakdown showing what the differences between limited versus diffuse are. Again, classification criteria. Crest syndrome. Previously used as a synonym for limited scleroderma, but basically this is for any type of scleroderma. This is that criteria for us to make sure that we're pushing that diagnosis. So, calcinosis, Raynaud phenomenon. esophageal dysmotility, sclerodactyly, and telangiectasis. No longer considered to denote limited scleroderma, but may show up in other literature. So it's out there, but it's basically scleroderma. These are the criteria out there. We get to see pictures with these ones. So diffuse scleroderma, diffuse. So you get that puffiness associated with early manifestations of the scleroderma hand manifestations. Diffuse again, finger joints contractors, right? So they get that tight, that prevents their movement. With crest, we talked about calcinosis, right? So you've got that skin tightening, digital flexure contractures associated with progressive scleroderma skin changes. We've got that severe calcinosis cutis, so it looks like they've got those stickers stuck on their hands, right? Not only is it seen looking at these fingertips out there, that x-ray shows of that calcinosis up and underneath of that skin. More stuff out there. That looks different. Skin changes associated with diffuse scleroderma. Those shoulders look like they got some shoulder pads on or something, but they don't. Changes there. Telangiectasis. So spider webs. There's France. Raynaud's phenomenon. Of those two hands, which is showing the Raynaud's? Is it the 3 over here or the 2 over the end? It's the white ones, right? So it's the ones that turn white are having that issue. And that is Raynaud's. Severe cases may be associated with digital ischemia and ulceration. So ischemia is just not having that blood flow. So they're becoming cold. You can't feel those things, like they're cut off. Most common treatments, cold avoidance, CCBs. Patients age 30 with new onset of Raynaud's should have an ANA and nail fold capillary examination. Especially if you have severe painful episodes of vasospasm, signs of digital ischemia or tissue damage, then yeah, we want to go ahead and be looking at that nail fold capillary examination. So we're going to scrape some of that away, and then we're going to get into the microscope. And that's what those things look like. You can see there's normal, early, active, and late. You see that cap blood flow is just gone. It's not there. So you can see that happen. Again, Raynaud's phenomenon, that's that. It's essentially showing that the scleroderma, like 90% of those will have Raynaud's, whereas the other things, they're going to have it, but it's not as intense as scleroderma. So now we're going to break it down into those systemic things that will be dealt with this scleroderma. So cardiac, usually subclinical in early stages of disease. Morbidity primarily seen in the last stages of diffuse scleroderma. So we talked about that. Diffuse, the most common death is associated with cardiac. Ischemia, reperfusion injury secondary to small arterial disease of the myocardium leads to contraction, band necrosis, and tissue fibrosis. So they get arrhythmias, cardiomyopathy, symptoms of heart failure, pericardial effusions, frequently detected on echo, right? So we're going to echo. Large pericardial infusions are associated with pulmonary arterial hypertension. That's a poor prognosis. The lungs was number 2 after cardiac. Chest pain, palpitations, dyspnea, on exertion, those are those things out there. Okay? Active interstitial lung disease occurs in patients with early diffuse scleroderma in first 4 years of illness. They'll also have some of that pulmonary hypertension. They'll have diffuse alveolar hemorrhage. That's rare, but they can have that. Test-wise, we can get some of the PFTs. 80% will have a restrictive pattern consistent with interstitial lung disease, so that ILD. We could do a high-resolution CT scan if we think that they're having some interstitial fibrosis. Monitor PFTs and echo. That's one of those things. If we know that they've got scleroderma, yeah, they're going to be having some routine things out there to just look into those, to monitor those. GI, upper and lower tract involved. Highly variable in clinical manifestations. Majority will have symptomatic GERD or dysphagia. Esophageal dysmotility of the upper GI tract and gastroparesis lead to that difficulty swallowing, severe reflux, GERD. If left untreated, can lead to esophagitis, esophageal ulcerations with bleeding, esophageal stricture, and Barrett. They can also get some of that AV malformation, telangiectasia, in the walls of the stomach. That's the upper GI tract. If it's the lower GI tract, then you get that reduced small or large bowel peristalsis, constipation, bacterial overgrowth, malabsorption, malnutrition, severe disease that can cause them to have some recurrent bouts of pseudo-obstruction, bowel distension with pneumocystis coli, intestinals, and even bowel rupture. So that's that GI stuff associated with scleroderma. Renal, we talked about, we've got that scleroderma renal crisis if it's diffuse. So occurs in only minority of patients. More common in diffuse. Again, I just said that. Abrupt onset of hypertension, so malignant hypertension. Most dreaded complication will be systemic sclerosis. 10% present without hypertension and have poor outcome. On lab-wise, they get that elevated creatinine, proteinuria, hematuria. So we saw that with those rheumo stuff. Onset usually within 3 to 5 years of disease onset. So that's that scleroderma renal crisis. Excellent response to ACE inhibitors. So if an individual with scleroderma is undergoing a renal crisis, an excellent response to ACE inhibitors. Number 1 cause of scleroderma-related death prior to the ACE inhibitor. Okay, so before cardio was the most common, renal was out there, but the ACE inhibitors added, then dropped it down. High risk to develop SRC, so you get those early stages of diffuse scleroderma, corticosteroid use, patients who produce antibiotics. Of course, one of the evaluations, one of the diagnostic studies to do would be that renal biopsy. Promptly initiate ACE inhibitors and titrate upward to control that BP. Musculoskeletal. Mild inflammatory arthritis can range from mild to erosive, like it's just getting in there like rheumatoid arthritis. Complications from tight skin over joints. We saw photos of those things with those flexion contractures, so that skin is so tight that it's hard to even extend those digits out. They can also have some tendon friction rubs. Again, most common in diffuse, so the ankles, the knees, the wrists. Myopathy syndrome, so they have that pain, prolonged muscle disuse, malnutrition, slow progression. You can see inflammatory myopathy in small subset of patients. Other things out there, similar to Sjogren's, we can have that Sika complex, so the dry eyes and mouth, decrease that salivary production, gum recession, usually less severe than in patients with primary Sjogren's syndrome. So it's like it, but primary Sjogren's is worse. Digital ulcers, talked about earlier, it's like they cut the tip of their finger off and you can see all that ulceration there that's causing bleeding. It hurts. It's no bueno. Rarely neuropathic pain, so carpal tunnel, trigeminal neuralgia. They can have erectile dysfunction, vaginal dryness, dyspnea, depression, pregnancy. If they are having pregnancy, then they have an increased risk for preterm delivery. Small for gestational age newborns, and possible hypertension. So there's that digital ulcer. Fingertip. Again, this is a breakdown back and forth, limited versus diffuse. So that would be something for y'all to keep up with, is this limited or is this diffuse? What is for limited, what is for diffuse? As such here, 52-year-old female presents with the following: a new onset of Raynaud's phenomenon, weight loss, dyspnea on exertion worsening over the past 3 months, changes in skin texture over the past 6 weeks with epidemia, pruritus, and pain. So do we think this is diffuse or this is limited? Diffuse, okay? It's not just on those hands. It's not just on those distal extremities. This is spelling it out for y'all, and then me asking you, is this limited or is it diffuse? I could put a differential diagnosis on there and throw Sjogren's in it, or I could do that kind of stuff. So that could be something for you to see. All right, y'all know I hate labs, but here we go. We're going to talk about the damn labs. So no single lab test is confirmed that of a diagnosis. Of course, we can run ANA on all these damn things, but then there's some other things out there that are there. So anti-poisoners, one antibiotics, they got that anticenturamine antibiotic. So it's just showing some of those things out there of what they could be. Again, y'all know I hate labs. Okay? Some things that I do like would be some of the imaging, some of those other studies, cases, things that we could be getting through them so that we can see. So pulmonary imaging, so a chest x-ray, no sensitive to diagnose, but it's one of those things out there for us to look at. Get that high resolution chest CT, so good for disease activity and severity. May see that fibrosis or that ground glass opacities. GI imaging, again, not needed, but we could do endoscopy, we could do barium swallow. Cardiac, we like these things, so EKG, echo, stress testing. So that's us looking at those function, ischemia, pulmonary hypertension, that. PFTs, baseline and every 4 to 12 months, depending on stage of the disease and the patient's symptoms. So what is their diffuse scleroderma rated as? To suggest the presence of that pulmonary hypertension, we can do two things. We can do it at isolated reduction of diffuse capacity of lung for carbon monoxide, or a reduction to rule out proportion of the degree, the decline of the FVC. Yeah, I would probably let someone else order that one. I'll stick with the PFTs and then refer them over to home. Let them do that stuff. We talked about that nail fold capillary evaluation. That's for us to see that Raynaud's phenomenon, because we see those capillary fill or caps aren't filled. They're not having that blood flow that's in there. Treatment-wise, each patient with scleroderma is unique with regard to disease features and prognosis. So no universal pharmacological intervention treats the disease as a whole. Combo therapy is often needed. Skin. We're talking about those drug early active inflammatory phase, so it's depending on if they're having that pruritus, that erythema, edema, puffy swollen fingers. And there's a list of those medications out there, okay? So MMF, remember that's that tetragenic one. CYC, methotrexate, gabapentin, IVIG, rituximab. We're not going to be doing some glucocorticoids because it's not recommended. It's just listing those things out there, okay? Treatment of Raynaud, cold avoidance, protective clothing, stress management, no smoking, avoid vasoconstrictive agents. Again, with Raynaud's, it's just like the exact same thing what we would do for Raynaud's phenomenon when it's with anything out there. First line medications, CCB, so calcium channel blockers, but we can use nifedipine, that's that CCB over there. We can get in second line medication, so let's throw them out some Viagra, topical nitrates, prostaglandins, SSRs, I don't list any medications out here. So it's talking about that there, okay? GI symptoms wise, eat small. Don't be eating before bed. Keep the head elevated. Avoid aggravating factors such as that tobacco, alcohol, caffeine. GERD, let's get them on some PPIs. Delayed gastric emptying, metoprolol, constipation, laxatives, octreotide, diarrhea. We do some antibiotics if we need to do those things. Consider probiotics in all patients. Physical therapy, glucocorticoids, they said earlier that is not recommended, but it could be used if we needed to. There's those same of the biological stuff that are listed here in regards to musculoskeletal symptoms. Calcinosis, there's no treatment. Surgery should be limited if it's severe. If they're holding those damn stickers like that picture before, then yeah, that would have to be some type of a surgical consultation. Pulmonary wise, we talked about that ILD. Again, we're talking about those biological medications out there. Pulmonary hypertension, stop smoking. Let's give you some O2, salt restriction, diuretics, and then it lists out some of those other meds there for that. Prognosis is variable depending on the clinical course. Reduced overall survival, limited. Diffuse, harder because it's more severe. Of course, we know that those clinical features that we discussed on earlier in this lecture, that is, part of the prognosis. So are they having that scleroderma renal crisis, anemia, pulmonary arterial hypertension, heart disease, tendon friction rubs, progressive lung disease? Or those are the things that will throw that out there, okay? Again, last slide. Most frequent symptoms, Raynaud phenomenon, GERD, skin changes, swollen fingers, arthralgias. Consider eval, of patients with Raynaud's phenomenon and features atypical for primary Raynaud phenomenon for scleroderma and another connective. A negative ANA makes the diagnosis of scleroderma very unlike. Degree of skin involvement is highly variable. Many patients with limited scleroderma have only subdural cutaneous findings, whereas the diffuse one is going to give us more of the bad stuff. Okay. Any questions on that? All right, last one before we take a lunch break and give you all some relaxation time. We're going to talk about inflammatory muscle disease. So autoimmune myopathies. This is 21 slides, and again, it's just going to be going through some of these things that we can see. So general considerations: polymyositis, dermatomyositis, immune-mediated necrotizing myopathy are a heterogeneous group of rare autoimmune myopathies. So autoimmune myopathies, this is basically them killing themselves. Okay, this is that stuff that is just eating it alive. Consists of symmetric proximal muscle weakness progressing over weeks to months. They will be having some of that elevated muscle enzymes routinely seen. So they'll have elevations of their CK, of their AST, ALT. They'll see a heliotrope rash, Gottfried sign papules, pathognomonic of the dermatomyositis. Incidence of 1 case per 100K per year. So it's not typical. Typically between age 45 to 60, dermatomyositis, that's what we're going to talk about the most, is typically distinguishable from polymyositis by the presence of a distinct rash. Most common presenting feature is muscle weakness. So they're having difficulty with their strength. Symmetric proximal muscle weakness evolving over weeks to months and the presenting symptoms of most patients. So you can do some of the proximal muscle groups, so neck, pelvic, thigh, shoulder, with symmetrical distribution. It's not just on one side, it would be on both sides. We can also have that of the hip flexors are the most common of the leg muscle. So if it's getting into the leg, then it's in those hip flexors. Low muscle endurance, difficulty with repetitive movements more than single strength. So difficulty walking uphill or upstairs, working with the arms above the shoulders, rising from the chairs. It's gradual. Distal weakness should occur only in the presence of proximal muscle weakness. So yeah, that's one of those things that is oftentimes seen out there. Clinical findings: arthralgia, myalgia, frank arthritis, severe fatigue, Raynaud phenomenon may also be present. They can have difficulty with breathing, right? So they've got that dyspnea, so that shortness of breath. But it's not because there's something wrong with the lung itself, it's because of that diaphragmatic weakness. So their diaphragm is having strength. Cutaneous, dermatomyositis only. It's got DERM in it, so derm, cool. All of these are pathognomonic. So Gatron's papules, raised, biologic lesions of the extensor surfaces, most common on the MCP, PIP, DIP. Heliotrope rash, as a red or purplish discoloration of the eyelids. It looks like hyperpigmentation, as we'll see in the photo coming up. Less specific rashes, you'll see a shawl sign, so it looks like they have that shawl around their neck. They can have a V sign. They can have hiker's feet, mechanic's hands, and we'll see pictures of these things out there. Mechanics and hikers, those can be painful, fingers and toes. So there's that heliotrope rash. So it's that reddish purple eruption of the upper eyelid. It can also get down onto the cheeks. So a heliotrope rash that can be confused with lupus, but you see this individual here has it on those nasolabial folds as well and there. So whereas that malarash in lupus skips folds and eyelids. So that's why it's a little bit of a differential diagnosis. Gottron's papules, talked about it is most common on the MCP, PIP, DIP. So you see those there on both of those hands, symmetric. V sign, shawl sign, so they got the shawl on. Mechanic's hands, that looks painful to me. More. Again. There's that V. So making the diagnosis or that evaluation, okay, major diagnostic criteria, muscle biopsy, if they're having that proximal muscle weakness. Lab-wise, we want to see, or we don't want to see it, we will see that elevated CK, ATALase, AST, ALT, LDH, abnormal EMG. So EMG is what? That's us testing of their strength of the muscle. And if the weakness is there, then it pretty much lets us know. And that of those rashes, dermatomyositis only, that's what we just looked at of those rashes that we just looked at the pictures. Here's labs, by labs. I talked about the EMG, talked about the MRI, talked about the muscle biopsy. These are those things that we could be doing. All patients in whom autoimmune myopathy suspected, unless pathognomonic findings of dermatomyositis is found, then we would do that deltoid or biceps to get a 4 out of 5 strength. So it's not 5 out of 5 like we want to be having that. Treatments. Goals of therapy include increasing muscle strength, controlling pain, enabling patients to manage their activities and daily living, as well as improving their quality of life. Mainstay of therapy focus on control of inflammation throughout immunosuppression for specifically dermatomyositis. Dermatomyositis, we'll be looking at corticosteroids. So a first line is prednisone. So that would be something for us to do. Prolonged, so we could do it for up to a year. Of course, we'll have to do of the tapers to get them off of that stuff. Yeah. Indicators that additional immunosuppressants are required include the following. So if they're having one of these, or having these things, then we'll get into some other treatments afterwards. The first line treatment that we're going to do is prednisone. But if they're experiencing complications from the long-term prednisone, the ability to taper without precipitating myositis. So we start to stop them on that, and then they're going to flare up. Ineffective after 2 to 3 months, rapidly progressive disease, then we would get into some of those other things. So these are the same ones that we talked about when we went through lupus and scleroderma. These are those biological stuff out there. So AZA, MMX, rituximab, IVIG, cyclospin, yeah, they're out there. Prognosis, very poor prognosis if associated with underlying malignancy. Otherwise dependent on severity of the muscle weakness. How weak are they? Extramuscular involvement, response to therapy if they're not getting any better. Hey, there's some other endo stuff. Cushing syndrome. Pulmonary infections. P. Girochi phenomenon. Pneumonia, I say phenomenon. Okay. So those are those room things. We went through 4 of those. I've got one last one to go through, and that is of a vascular stuff that is associated with rheumo. So we will do that right after lunch. It's 11:47, so let's start up at 12:50, and I think I'll be done before 2, and then you can see Dr.